Macular degeneration. The disease is considered the leading cause of blindness in older Americans. There's no cure for the condition and no treatment for its most common form, which accounts for about 85% of cases. But Dr. Andrew Lamb, a macular degeneration specialist, says that doesn't mean there's no hope for patients like Evelyn Calleva and others. I first asked Dr. Lamb, what is macular degeneration?
It is a leading cause of blindness, of legal blindness in Americans over 50. It is probably the leading cause. And it's a condition of the macula, which is in the rear part of the eye. It's part of the retina. It's what we use to see straight ahead, fine detail, like reading words, seeing faces. And what can happen is with age, the macular cells, the photoreceptors of the macula, can literally degenerate and cause severe vision loss, distortion of vision, blurry central vision. And there are two types, dry and wet.
Yeah,
That's
dry
right.
and wet. So what's the difference? Because one is more treatable than the other, right?
The dry kind is the more prevalent one. I'd say about 85 to 90% of patients with macular degeneration have the dry kind. And actually, that's the preferable one to have because it moves slowly. You could have dry macular degeneration for years and actually have very little change in your vision. The wet macular degeneration form is much more acute. It's about 10 to 15% of patients, and that's characterized by leaking or bleeding blood vessels under the macula, which severely distort the vision and cause severe vision loss.
And so then do you actually see that in the eye?
Yes,
Yeah,
yes. We can literally go in there with our lenses and look and see leaking blood vessels or bleeding blood vessels under the macula. We have various imaging techniques like a scanner that can clearly show the fluid under the macula.
And so, Evelyn, you're a patient of Dr. Lamb's,
Yes,
right?
I am.
And how did you first become aware that you had macular degeneration?
When I was going to my ophthalmologist for yearly exams, he pointed it out to me and referred me to Dr. Lamb.
Yeah. And do you mind my asking if you have the dry or the wet form?
I have both actually, have the wet in one eye and dry in the other.
Wow. So I didn't even think of that as a possibility. So you're treating two different things kind of at the same time then?
Right. Well, actually, most people start out having the dry form for a period of time, and then what can happen is it can convert into the wet form. It doesn't mean you've stopped having the dry form.
And it seems like that we're hearing about this more. Is it because people are being diagnosed with it more often, or it's becoming a larger problem? What would you say?
Well, a lot of it is because the aging population. I mean, we're all living longer. 50 years ago, people didn't really talk much about macular degeneration because people didn't necessarily live long enough to actually recognize it as a problem. So now we're living longer, we're healthier, and our standard of living, our standard of care is much greater. And as you were alluding to, we have now treatments that can actually do something about it. It wasn't that long ago. When I was in training, I still remember when we didn't have any effective treatments for the wet form of the disease, people would come in with severe vision loss and we really wouldn't be able to do much for them at all. And it was quite depressing. Now we do have some treatments.
And so how are you working with Evelyn and how is it going?
So the natural history of wet macular degeneration is to get inexorably worse. I mean, you basically lose, you retain your peripheral vision, but all central vision.
It starts to get very cloudy in the center of the eye,
It gets very distorted
right?
and cloudy, that's right. So the medicines that we use are actually injections in the eye. We numb the eye, it doesn't hurt, or sometimes you feel a little pinch of pressure, but it's very tolerable, and Evelyn can speak to that, I hope. But the medicines are very effective at, number one, stabilizing the vision and preventing further loss, which again is a major victory because the natural history is to just keep losing vision. And some patients get improvement.
And so, Evelyn, for you, you've been seeing Dr. Lamb for about 4 years. Where are you? How's your vision?
Actually, I've noticed lately it's a little bit better. Most of my difficulty is when I'm reading. It becomes very blurry, but with adequate lighting and sometimes a magnifying lens, I don't have a problem.
So you've made a few adjustments there based
Yes.
on what you've noticed?
Yes.
And is that something that you recommend to your patients, maybe lifestyle changes to help themselves in the interim?
Well, to be honest, people often ask me, what can I do to try to improve my chances of not getting macular degeneration or reducing the risk of it getting worse? Unfortunately, it's really age-related. It's actually called age-related macular degeneration. So there's a limit to what we can do to necessarily inhibit it that much short of medications. You alluded to the fact that one has a treatment. That's actually the wet macular degeneration, which is the worst of the two conditions. The dry macular degeneration, although a lot of research is being done in that area, actually doesn't have a really effective treatment. yet.
Yeah, and there was a recent story in the Boston Globe, you point to the age piece, but the story in the Boston Globe pointed out that someone's 48 years old is also being diagnosed with this. So is technology getting better so we're seeing it earlier in folks and helping them, or is this becoming something that's a problem for younger people?
Well, I don't think, we've always been able to clinically diagnose the condition, so I don't think there's a real change in the prevalence of it among young people. We know that basically if you're over 50, it's essentially old enough to possibly get some early signs of dry macular degeneration. But the treatments that we're working on are to basically slow down the worsening of dry macular degeneration. There are definitely a lot of companies, a lot of research studies working towards that.
And in terms of prevention, is it about wearing sunglasses? Is that really kind of the only thing you can do? You see little kids wearing sunglasses now.
We do think that it could be beneficial to limit your exposure. Sunglasses are always a good idea, but it's not something that's so obvious that we tell people you have to wear sunglasses all the time.
Another thing that the Boston Globe pointed to was gene therapies. And when you read about them, sometimes it sort of seems like the stuff of science fiction, but do you think there's actually hope for people that
Absolutely.
You might cure this one day?
Absolutely, there's definitely hope. I mean, if you look at 10 years ago, again, we didn't have these medications and people were literally going blind before our eyes and we couldn't do much. 10 years from now, I'm sure there's going to be wonderful options. So we're studying stem cell therapy in particular, gene therapy as well. Gene therapy has a lot of promise for inherited retinal diseases, not necessarily like macular degeneration. In fact, the first...
Which is something that's kind of anyone could get, right?
Right, well, it all depends on your genetic history, but with the gene therapy, you have to identify a malfunction in a gene, and then you want to replace it or correct it. But when it's a multifactorial disease like macular degeneration, which is essentially related to age, which nobody's going to be able to change, it's more difficult to find a target. But stem cells, for example, have a lot of promise. There's definitely early phase studies being done where essentially if you were able to take a stem cell and possibly rejuvenate or regrow functional retinal cells under the macula, that could be amazing. But it is in a very early stage. But believe me, a lot of people are working on this.
Something else I want to ask you about is cost. You wrote an op-ed back in 2015 for the Washington Post, and you pointed out there's a $50 treatment that you are quite fond of versus a $2,000 treatment.
That's right.
Are you still, do you still believe that the $50 is just as effective as the $2,000?
I don't not only believe it, but we know that that's true from science. So this is a very interesting topic that essentially touches on much of the drug costs and the controversy over drug costs in our country. Briefly, we have 3 medications for wet macular degeneration. One is called Avastin, and that's very inexpensive, about $50 a dose. And 2 other ones are called Lucentis and Eylea. Those are about $2,000 per dose. And
they do the same thing,
They do the same thing. Now, some studies have shown very slight, not statistically significant differences in maybe the OCT study we do that shows how much drying of the macula there is, but practically speaking, they're equally safe and equally effective. If one doesn't work, you could always switch to see if another one might work. Frankly, most of the times when that happens, there's very little difference in my experience, but it's an ongoing debate that's definitely very interesting and has a lot of ramifications for our national health system, our health system in general.